Director of the Centre for the Health Economy at Macquarie University. And this is a presentation on getting more value from mental health care funding and investment. I just wanted to start off with an acknowledgement of country. So we acknowledge the traditional custodians of the land on which Macquarie University stands, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since time immemorial. We pay our respects to the elders past and present. Just a little bit of housekeeping. If you could please keep your microphones mute throughout, well, at least throughout the presentation, that would be fantastic. You can obviously use the chat function, put in questions or comments. I'll be speaking for around about 45 minutes and then I'll leave 15 minutes for questions. Okay, so just to kick this off, this is a presentation on getting more value from mental health care funding and investment. Just to make some acknowledgements. So this is some research that the Centre for the Health Economy is undertaking from a grant that we received from the National Mental Health Commission. The views that we present within this presentation are those of our authors, including myself, and those co-authors are Alicia Norman, Anand Bilgrami, Mona Agdi, and Olu Adiona. So there is a vision within the mental health care system that is set out in the National Mental Health and Suicide Prevention Agreements. The objectives really for the mental health care system going forward are several, but some of those are to create a unified and integrated mental health care system, to deliver a mental health care system that is comprehensive, coordinated, consumer-focused and compassionate, to reduce system fragmentation through improved integration, and to ensure that there's equitable access to appropriate levels of mental health care needed. The Productivity Commission in their 2020 report was comprehensive in their analysis of the system. They identified what they termed as a missing middle, which are a group of consumers that are of quite high needs, but not high enough to be an inpatient. And that missing middle was really determined by the fact that these people are missing services in the community and also non-acute bed-based care. The Productivity Commission also noted that too many people are receiving some of those services for the middle that could otherwise be dealt with through other services such as self-help and telehealth services. But the Productivity Commission also recognised several deficiencies in the mental health care system. It suggested that roles and responsibilities were unclear across the federated structures. It identified the fact that mental health care data was underutilised and fit-for-purpose data wasn't available for decision-making. They noted that there was little measuring and monitoring of health outcomes, and programs weren't being measured for their cost effectiveness before being scaled up. But the Productivity Commission also made some recommendations around reforming mental health care funding. They didn't go so far as to say mental health care funding should go down an outcomes-based funding pathway. And their primary reason was the fact that they believed that outcomes weren't being measured well enough for that at this stage. But what they did do is they started talking about bundling some payments together and also further commissioning of services. So in primary care, for example, they suggested that there should be co-funding of MBS-related mental health care services by regional commissioning authorities. In emergency department and inpatient public hospital mental health care, they suggested that there should be some budget responsibility for emergency department presentations and inpatient admissions, and also incorporating mental health care related hospital avoidable readmissions into broader activity-based reforms. In community ambulatory mental health care, they suggested the shift towards an activity-based funding model, which we're seeing. but while waiting for that using a fee-for-service payment model. And then they also suggested in psychosocial support services creating some more flexibility around the way primary mental health care can commission their services, and also state and territory governments to establish RCAs to commission psychosocial support services. Now, as I said, they didn't recommend outcomes-based funding, but it's not to say that they didn't want outcomes-based funding. They thought it was impractical. What our research does, and this is a seminar to talk about our consultation paper, but what our research does is we're looking to start where the Productivity Commission finished, to develop a framework for embedding value into Australia's mental health care funding and investment environment. So that's looking to build on reforms outlined within the National Mental Health and Suicide Prevention Agreement, but to also extend the analysis and recommendations made by the Productivity Commission in their inquiry into mental health care. And within our consultation paper, which has been released a few weeks ago, if you don't have a copy, please download one. Our focus currently is on funding and investment to improve mental health outcomes for the missing middle. Now, how does that align with broader directions? Well, there are some directions that are occurring elsewhere within the system. The MBS Review Task Force noted that MBS be complemented with alternative funding models to improve health outcomes, suggesting that there should be some exploratory analysis around bundled payments. The National Health Reform Agreement has 2 of its 6 principles that directly relates to value. One is paying for values and outcomes, and the Reform Agreement is effectively an agreement between states and territories and the federal government to head down the same pathway of national healthcare system reform. The second principle out of 6 that related to value was to develop a nationally cohesive health technology assessment. And while they were sort of referring to services that are delivered within hospitals, for example, we can take a broader approach to that health technology assessment definition to suggest also that it should include services such as mental health care services outside the hospital. And then finally, the Independent Health and Aged Care Pricing Authority has obviously been going down this pathway for a while. It's introduced the Australian Mental Health Care Classification System and activity-based funding. Okay, so embedding value into mental health care funding. So this seminar is really a summary of our consultation paper. And the consultation paper starts off with an exploration of what are value-based payments. It then moves into a chapter on introducing or embedding value-based payments into mental health care funding. And it also explores a framework for introducing a more systematic approach to making investment decisions in the mental health care system. So that will be the format of the subsequent slides. So what are value-based payments? Well, in very broad terms, value-based payments are payments that seek to use financial incentives to provide an extrinsic motivation to change behaviours. And if we look at our system currently, we know that there are very little examples of value-based payments that are being used, although there are some pockets within the healthcare system. Mostly primary care funding is obviously supported by fee-for-service through the MBS. It doesn't provide any reward or encouragement for delivering quality care or improved health outcomes. In actual fact, introduces incentives to increase volume rather than value. Value-based payments are really defined by how value is defined, and there are many ways to define value. The original value-based healthcare movement, which was effectively developed by Porter and Teesberg in 2006, they defined value as effectively a ratio of outcomes to costs, and they defined their outcomes as capability, comfort, and calm. That broad framework has been adopted elsewhere throughout the world, and in particular within New South Wales, who have gone down a value-based healthcare pathway, but with a broader definition of value to also include patient and provider experience. Value-based payments can be defined as either first generation, which we've seen most of over the last 20 years in pilot programs, so pay for performance and capitation. But also there are some new value-based payment models that are being introduced called bundled payments and accountable care organisations. And that is mostly being pursued in the US. They have a particular mandate to try and arrest their expenditure growth in healthcare, which I think is about up to 18% of GDP at the moment. But bundle payments and ACOs basically work by contracting multiple providers to deliver a pathway of care, and through that pathway improve health outcomes and reduce costs of care by removing some care that is deemed effectively unnecessary because it doesn't result in any significant improved health outcomes. But value-based payments really work around financial risk sharing. And here is a schematic that we've developed that really shows from the bottom left-hand corner to the top right-hand corner what value-based payments, how value-based payments sit on the broader spectrum of that sort of financial reward provider risk trade-off. And you can see down on the bottom left-hand corner, sorry for the acronyms, but those acronyms are displayed in the note below. But you have cost reimbursement, retrospective cost reimbursement, which is effectively no risk to providers because it means that whatever costs they incur, that they will be reimbursed on that basis. But typically it doesn't provide any reward either, given that there are no margins to make. If we sort of move up this from the bottom left to the top right, in this first component, non-value-based models, we also see that it includes historical block funding, fee-for-service, obviously MBS, and also activity-based funding, where they don't really incentivize quality outcomes. They incentivize volume, and in activity-based funding, it's more around incentivizing improved efficiencies. We then get into that sort of the value-based models, pay for performance, PFP, capitation. There's various capitation type models, bundle payments, and then accountable care organisations. You can see that as we move up that way, provider risk increases because effectively we're just shifting financial risk from a payer to a provider. But the way that these models work is that they're meant to generate provider financial reward for improving health outcomes and reducing costs. The other component, though, particularly for mental health, is this relationship between mental health, physical health, and non-health factors that impact outcomes. And this really needs to be considered within the context of value-based payments because we don't typically have a defined episode of care within mental health, like, for example, knee replacements, where you go in for surgery, you have your surgery, you come out of surgery, and then your outcomes are typically defined by the treatment that you've received. Mental health, it's a little trickier, so it's harder to define what value means. There are other factors that impact mental health outcomes, such as your socioeconomic status, whether you're receiving other formal or informal care, and health-related behaviours, for example, alcohol consumption or drug use. That means that there is a component of mental health that also needs to be incorporated into physical health. And so within the consultation paper, what we have recommended is that if we are to go down the pathway of embedding greater value into mental health care funding, that needs to be done at a whole system level. And so this is a schematic that's within chapter 3 of the report that outlines what we're proposing within the mental health care system. So we're basically saying for value-based payments to be introduced and to embed more value into mental health care funding, we need an independent value-based payment authority. That authority needs to be representative of not only mental health funding, but also all other types of healthcare funding, and broadened out to other types of services that could potentially be used to improve to improve mental health care outcomes. So, for example, housing, education, and other types of services that are non-related to health, but in fact do impact health outcomes. The role of the Independent Value-Based Payment Authority is to develop and develop and then pass to state and territory governments to implement value-based payment models. Now, that could include pay for performance or capitation, but also bundled payments and accountable care organisation type arrangements. That Independent Value-Based Payment Authority would receive input from patients and carers, providers, PHNs and LHNs and other stakeholders. But also there would be some representation from state and territory government departments and federal government departments to make sure that those silos can be broken down between federal and state funding across mental health care services. There'd be enabling independent government agencies working into the Independent Value-Based Payment Authority, for example, the Australian Digital Health Agency, and there's a potential role for private insurers as well to participate in a payment model, because as we know, private health insurers also want to in some ways manage their costs associated with mental health care, particularly inpatient mental health care. The idea is for that Independent Value-Based Payment Authority to develop those models. It would then be provided to the state and territory governments to implement them either through PHNs or LHNs, PHNs and LHNs combined, or what the Productivity Commission defined as regional commissioning authorities, which are similar to PHNs and LHNs, i.e. they combine the two, but use their own independent entity with a board. Those funding models would then go through providers, and then the Independent Value-Based Payment Authority would assess those models after a number of years. Now, what we're saying is that too often payment models have been piloted on a framework that has been way too short, 1 or 2 years. We expect these models to be implemented and piloted over 5 years, for example, with continual evaluation throughout. We're also suggesting that as a pilot, it needs to be part of a bigger program of value-based payment models that is supported by, for example, a strategy, a 10-year strategy, and a commitment from government to say, we are looking at implementing value-based payment models. We have X amount of funding allocated to that to provide states and territories, but also providers with a vision as to where a program of payment models and the learning process that would go along with that. Of course, those models would have to be evaluated by independent organisations, either academics or consultancy evaluators, for example, to ensure that those learnings are independently derived. There would need to be several principles for mental health care funding. Here are a set of principles that could potentially be used, and if you go onto our website, you'll notice that there is a consultation process that we are undertaking at the moment. There's opportunity to participate in a workshop over the next month. But here are a set of principles that would need to accompany any sort of development of value-based payment model. These were adopted from the National Mental Health Performance Framework, but they equally apply to funding models. For example, ensuring that there is accessibility, choice, continuity of care, equity and effectiveness through any model that is implemented. There are obviously challenges associated with introducing a payment model, and we'd be happy to hear about more challenges that you may identify. Understanding and sharing financial risk between providers and payers will be difficult. So we'll be moving from, for example, a fee-for-service or an activity-based payment arrangement whereby there is some certainty around payments to a financial risk model whereby there is more uncertainty, particularly for providers around the funding that they may receive. And the question is, well, how do payers and providers manage that financial risk appropriately? There may be some complexities around ensuring providers are willing to participate in a new funding model if there is greater uncertainty. And in the US, we've seen that in voluntary schemes, there is potential bias associated with those who self-select into these programs. And they're not necessarily the providers that you want to get into these programs. There'll be some challenges around measuring costs across treatment pathways. So even though, for example, you have good cost measures in public hospitals, we know little costs around we know little around what is the actual cost of delivering care across a treatment pathway, if we also include primary care and community care in that pathway. There'll be costs associated with developing new care pathways. Even just developing a bundled payment, for example, will require developing new relationships, investment in new care pathways, investment in potentially new technology to be able to share data amongst providers to monitor and manage individuals as they move through those care pathways. Collecting and sharing of data on mental health outcomes and costs. So moving towards a value-based payment model will require much more data to evaluate outcomes and costs, and there'll need to be some investment in infrastructure around that. And then also the process around risk adjusting prices to ensure that providers who provide care to patients with more needs are compensated appropriately. The two primary challenges, though, I think are, first of all, measuring outcomes and then attributing outcomes to care. And we can see here that if we are to measure outcomes, we need to account for a whole bunch of different things. Here is a chart which basically shows the probability of identifying a causal and attributable relationship between provider action and inaction and a quality indicator. And there are several challenges to that, in that as you go down this pathway, you can see that there are potential errors along the way that can create a disconnect between that quality indicator and the provider action that needs to be accounted for. So, for example, random error, systematic error, potential confounding from other factors that impact the quality or the outcome indicator that aren't included within the analysis would need to be addressed. And then again, looking at how we attribute that care to the health outcomes. And here is a chart that basically shows, you know, best clinical care is only one component to delivering health outcomes. Health outcomes can also be impacted by the social environment, informal and formal care, health-related behaviours, as I've mentioned, but also some systemic and random error within the care delivery itself that may not be reflective of the actual care that's delivered at a program level. Okay, so that's the section on embedding value into funding models. We're also looking at embedding value into mental health care investment frameworks. And this is chapter 4, I think, of the paper. And it really stems from the fact that the Productivity Commission's findings suggested that many investment decisions were not based on evidence of effectiveness or cost effectiveness. Evaluations lack transparency, accountability, and independence. And also research outcomes were not used effectively by policymakers. And obviously that's a concern when we're investing in programs that we know little about as to whether they're generating the appropriate health outcomes. There's a huge potential opportunity cost associated with that, because that funding could be used elsewhere within the mental health care system to deliver better outcomes. There was a recommendation that was made by the Productivity Commission, although it was you know, a relatively quick recommendation. That was around governments requiring all funding applications for mental health interventions to include an economic evaluation. And then also that all new mental health interventions should be first trialled as a pilot program before being scaled up. Now, we generally agree with the first recommendation, but the second recommendation is being trialled by as a pilot is not, from our perspective, necessary always. In particular, if you have good information around the potential outcomes associated with that program. So what we have proposed is effectively a unified national approach to deciding on alternative investments in mental health care services. We want it to be pragmatic, so we don't want it to be excluding potential investments that should otherwise be implemented but may not be because there is some uncertainty around their effectiveness. We want to make sure that there is a framework to capture some of those programs and to make decisions on those programs with the potential to collect additional data as that program is implemented on a conditional basis. We want the approach to be efficient and risk-based. And when we say risk-based, we don't want the investment approach, for example, to be applied to a $1 or a $2 million investment because the administration costs are likely going to be too high for that. This is for major investments into mental health care. The approach employs a formal evaluation approach to mental health care investment and also post-market surveillance to monitor outcomes and cost effectiveness. And our approach also aligns with the broader directions that are outlined in the National Health Reform Agreement. And that one principle was really around the nationally cohesive health technology assessment, which I mentioned prior. Now, there are examples of a systematic approach to government investment decisions, so this is not such a crazy idea. And there are several examples, both at federal and state, and we picked out some federal examples. So one is the Office of Impact Analysis, and so which is run by the Department of Prime Minister and Cabinet. And there is an approach to evaluating the impacts of government regulatory change through that Office of Impact Assessment. And it's a formal approach. It uses a net benefit criteria to determine as to whether that regulatory change should occur. There's also the more familiar Federal Pharmaceutical Benefits Advisory Committee, who advises to the Department of Health and Aged Care on listing pharmaceuticals on the PBS for public funding. And Australia was the first country in the world to legislate that evaluations of pharmaceuticals had to go through a cost effectiveness lens before they're recommended onto our subsidised program. And then at the state level, we have examples such as New South Wales, who have their New South Wales Gateway Policy that's run by New South Wales Treasury. And that policy is applied to significant capital and recurrent New South Wales government expenditure across all departments, including the New South Wales Health. There's also several principles that could be used to underpin a mental health care investment evaluation process, of which we're suggesting. So ensuring that an investment is fit for purpose, maintains social license, ensure that the process for evaluating the investment is independent and transparent, ensuring that a process is person-centered, so making sure that the consumer is at the center of that investment evaluation as the key criteria, and but also ensuring that there is net value to the Australian economy and society, which aligns with some of those other processes that are used. So just to go through the process of which we're recommending, so this is a process which is sort of has been cobbled together by looking at other processes that have been used within Australia, both at the state and the federal level, but applying that to a mental health care focus. So here we have at the start a sponsor. It may be, or it's most likely going to be, a state or a territory government or a federal government who wants to evaluate a potential investment in the mental health care system. It may be a large investment. It may be an investment across not within only the healthcare system, but it may be a combination of healthcare and housing, for example. That sponsor would submit an investment dossier to a federal government department or agency to ensure that there is a single entry point. The first assessment would be as to whether it would have any major impact on stakeholders. If not, back to the sponsor for implementation. That's where that sort of risk management approach comes to ensuring that we're only evaluating programs that have potential higher risk of failure, for example. There would be a determination as to whether that investment should undergo a full or a partial evaluation based on characteristics it holds. There would be evaluation guidelines that are transparent, and that the evaluation would be published on a government website. Now, the evaluation would then feed into what we have termed a mental health advisory committee, which would comprise of several independent members of that committee, determined by state and territory, plus also federal governments. It would be supported by 3 subcommittees. One would be the lived experience subcommittee, the second, the clinical subcommittee, and the third is the economic subcommittee. And the reason for that is that we know that mental health care programs are not going to have the same type of evidence that, for example, a pharmaceutical may have. And so we need to ensure that that uncertainty can be dealt with through some of those committees as well. Now, the Mental Health Advisory Committee would make a recommendation to the sponsor, whether it's state, federal, or territory. And now that recommendation doesn't necessarily have to be implemented by the minister, but there does have to be a transparent process. And that's the whole point of this, really, is to ensure that if that recommendation isn't implemented, then there is a transparent reason as to why that's the case. The question as to whether to implement, if no, back to the sponsor for potential adjustments. If yes, there is potential for post-market assessment. Now, this will really come down to how uncertain is the decision. If the recommendation, for example, suggests that the investment should go ahead, but there is some uncertainty as to whether it will deliver the benefits proposed, that assessment could include an implementation of a specific time period, but with an evaluation plan attached to that to collect information on the program. If there is some certainty around the benefits associated with that investment, then it could be implemented with just a monitoring plan. And here is just further information about that post-market assessment. So if it was to go down an implementation with an evaluation plan, it could either be a pilot approach, implemented on a conditional basis. So, for example, implemented based on hitting key targets, or it could be implemented using a pilot approach where the government undertakes a pilot and then it is re-evaluated. There's also some identified challenges. So defining investments that should be evaluated through the framework, we would need to think about that. There's various ways you could do that. You could take a value approach. So, for example, anything above $20 million could go through that focus. It could be a service approach, an investment type approach where it is just services that are evaluated rather than, for example, infrastructure. Or it could be even an investment reach approach whereby it may be, for example, just investments that are either cross-portfolio or cross-jurisdictional investments. Alternatively, it could be a combination of all three. There will be a challenge in embedding this type of framework in a strategic plan development and evaluation. So at a local and a state and a federal level, how do we incorporate something like this within strategic planning, particularly if that strategic plan, for example, is over 5 or 10 years, being very prospective in terms of what investments should be implemented, or even using this approach to say, well, how are we travelling with some investments that are within the strategic plan? It may be quite challenging if the government is beholden to that strategic plan. Ensuring the framework can capture uncertain but potentially innovative investments. So we've outlined some of that already within the structure, but it still could be quite challenging because there has been some concerns within medical devices, for example, whereby just some of the information is not available, even when you have a subcommittee to make a decision that can be upheld through the information that's provided. And then finally, embedding the framework into government investment decision process, for example, cabinet decisions and the way that the budgets are set each year at the federal level. Just to, if you haven't seen the consultation paper, this is a copy here, Getting More Value from Mental Health Care Funding and Investment. It has a lot more detail in terms of what I've just outlined. This seminar was really to give you an introduction to some of the key components of that consultation paper. As I mentioned, we are going through a consultation process throughout September. We're undertaking interviews with all state, territory and federal health departments and mental health commissioners. We're also undertaking 3 workshops in September with all stakeholder types. So please, if you haven't signed up to one of those, get on board. It's going to be a 2-hour workshop where we really get into some of the details around trying to answer some of the questions that are within that consultation paper. They're held on the 13th, the 14th and the 26th of September. And please send this invitation around to your networks as well if you believe they would get something out of it. And if you're looking to register your interest, please go to our publications page on our website, where you'll get access to the consultation paper, where you can register your interest to attend the workshop, and also you can get details for providing a written submission. So that's me, and that's the presentation. If you have any questions, please put them in the chat, or please feel free to unmute yourself, and I'd be happy to answer those questions.